Now, not all pituitary tumors need surgery. For us, there are 3 indications for operating on pituitary tumors. And the reality is that probably 9 out of every 10 pituitary tumors we see, we don't operate on. Between 2006 and January of this year, we had seen over 1,400 pituitary tumors, and we had operated on less than 10% of them. The other 90% we're just watching. And the reality is that most pituitary tumors are benign. Most of them don't need surgery. Most of them, if they do grow, at such a slow rate that patients are going to die or have problems from something else first. So we have some pretty strict criteria in terms of determining whether or not someone needs surgery in this location of the brain. The first criteria is if they have a pituitary tumor that secretes a hormone. Cushing's disease causing acromegaly is due to pituitary tumors secreting too much growth hormone. Well, unfortunately, we don't have a special medicine that's really going to reverse that. And having too much growth hormone in your system can cause heart attacks, diabetes, and strokes. So the only way to fix the excess hormone in those patients is to remove the tumor. Likewise, Cushing's disease, Cushing's syndrome, is from excess cortisol in the system. That too can cause heart attacks and strokes, diabetes. And unfortunately, we don't have a magic pill that's going to make that better. And so the only way to get rid of the excess cortisol in the system is to remove the tumor. The other classically described hormone-secreting tumor are called prolactinomas. Now, fortunately, that one is the most common of the secreting tumors, and that one actually has a treatment that doesn't require surgery. You can give those patients either bromocriptine or cabergoline, and both of those medicines work very well to help shrink the tumor and decrease the prolactin levels. In some cases, patients can't tolerate the medicine, or the medicine doesn't work, of which case we're now left with a patient who has a tumor secreting too much hormone that, again, the only way you can get rid of it is by removing the tumor. So what we're trying to develop are ways to cure the problem without causing deficits to the rest of the body. So the first indication for operating on these patients is secreting too much hormone that we can't treat with meds. The second one is that if you have a tumor that's already very large and they're losing vision from it. The reason they lose vision is because it's compressing on the optic nerve, or they could have double vision by compressing on the cavernous sinus. And the only way to really reverse that is to take the pressure off those structures. So that's the second indication for surgery in these patients. And then the third reason is if it's growing. So all of these patients that we're following, we follow them with serial MRIs. And if down the road their tumor is showing evidence of growth, we will often talk to them about surgery for it, because if we've documented that it's growing, we know it will continue to grow, and we want to remove the tumor before they do have visual compromise or more pituitary disturbances from compression. Now, obviously, if the patient is 80 or 85 years old and their tumor has grown 3 millimeters over 2 years, we're not going to talk to that patient about operating because they don't need it. But we're talking primarily about the younger population. So the traditional approaches for pituitary tumors relied primarily on what's called a microseptal transsphenoidal access to the sella. And I'll show you some images of that. But for the larger tumors, that's not always the best case scenario, and you often have to have what's called a craniotomy to try to debulk or remove as much of the tumor as possible. The outcomes from these tumors is directly related to how much tumor you can remove. If they have a hormone-secreting tumor and you don't remove every last cell of that tumor, you haven't fixed this patient. They're still going to have excess hormone in their body, and they're still at the same risk as if you left the tumor in. So this is the traditional, what we call transsphenoidal approach. This is actually probably what 90% of people around the country are still doing for these kinds of tumors. And what it involves is putting a speculum in the nose. They make a little incision right here. They go down right along the septum, and then through that little tube they have a microscope, and they look down the pipe that is illuminated by the microscope, open up the back wall of the sella, which is right here, and then start pulling the tumor out through that little tube. It's a very eloquent surgery. They've been doing it now for 20 or 30 years. It's still fairly popular, but it does have some limitations that we'll talk about. For the larger tumors, we end up doing craniotomies because through that little teeny corridor, you can't see all of the tumor. You can only see what's on the other side of that tube. And so when you're a surgeon and you've removed all the tumor that you've seen on the other side of that tube, you're left with one of two decisions at the end. Either you can start to blindly poke around looking for more tumor in other areas that you can't really see, knowing that there are carotid arteries there and optic nerves there, or you stop, leaving some tumor behind. And so that's been one of the problems with the traditional transsphenoidal approach, is that for larger tumors, you're probably going to leave some tumor behind. For a 1 or 2 centimeter macroadenoma or for a microadenoma, it's probably fine. You'll be able to see everything you need. But for the larger tumors, it could be an issue. And so there are some new approaches that we're now using. A craniotomy is what most people will do for a large tumor. And by doing a craniotomy, you open up the bone, you lift up part of the brain, and you remove the tumor. But it also has some problems. One of the problems is that you have to retract on the brain. You have to expose the brain, and that can cause damage. The recovery from that kind of surgery, patients aren't going home in a day or two. They're in the hospital anywhere between 3 to 7 days, depending on how involved it is, and the recovery is more like 6 to 8 weeks. In addition, when you do a craniotomy to remove these tumors, you often can remove a lot of the tumor that's on the top. But the tumor that's actually sitting underneath the optic nerve and in the pituitary itself is very, very difficult to reach. And even though you've made a big opening, you often will leave tumor behind with that approach as well. This is kind of what that surgery looks like. I know it's dinner time, so I'll go through that quick. But that's basically what we're trying to avoid with minimal access brain surgery. So for the past 7 years, this is actually what we've been doing to address these tumors. Where we take a small endoscope, we go through the nose, there are no incisions here, there are no big tubes put in the nose, basically taking that endoscope and going straight back. So to put it in perspective, this is the traditional transsphenoidal approach where you have a microscope and you have this speculum in the nose and you have this tube of light that's going straight back to the pituitary gland. What we're doing different here is that there's no tube, it's an endoscope, and it provides what's called a cone of light. So you actually have a larger field of visualization, and the intensity of the light is right on the area of interest. So the area is much brighter, and you can actually see it much better. This is what we're doing different. Neurosurgeons started doing this in the early 1990s initially. It became more popularized around 2000, but the ENTs obviously have been using these endoscopes for now over 20 years. This is our basic room setup. The surgery is done not by a neurosurgeon and not by an ear, nose, and throat doctor, but together as a team. And it makes sense why. The surgery is being done through the nose. I'm not a nose surgeon, and the ENT is not a brain surgeon. But by putting our skills together, we can now do something that we can't do individually. We're allowing to get to the brain through the nose. The ENT protects the nasal passageway from the neurosurgeon, and the neurosurgeon protects the brain from the ENT. And we basically work, I tell people, we're like a fighter pilot team. The ENT's job is essentially to get us to where we need to go. Open up the paranasal sinuses, get rid of deviated septums, get us the exposure to the base of the brain. And then my job is I'm kind of the gunner in the back. My job is to get rid of the problem. And then when we're all done, we fly home. And so it works very well that way. When we do this, we each have our own monitor that we're watching. There's usually a circulating nurse there. As you can see here, Dr. Spector is holding the endoscope, and I'm dissecting away at the tumor. And we actually have 3 hands and 1 nose. But it allows us to be very dynamic, and I am dependent on him to be able to provide me good visualization as I'm operating in these areas. And so having a very good sinus endoscopist with you is invaluable, and without that, this can't be done. We use a lot of technology when we do these procedures. As you can see, we have 2 high-definition monitors. There's often a monitor in the back of the room so the anesthesiologist can see what we're doing. God forbid we were to nick a carotid artery and we start having profuse bleeding. I want him to know what's going on because he knows what to do with anesthetic agents and how to control the patient systemically while we're trying to fix the problem. And we also have this thing right here. And this is called a navigation camera. And we use what's called neuronavigation for these surgeries. And what neuronavigation is, it's basically GPS for the brain. And so before surgery, well, we'll skip to that. We'll come back to it. Well, right now we're using Stryker, but we're using Stealth for several years, and we've used BrainLab. But with neuronavigation, what it allows us to do is actually use kind of a probe. And we can actually use the probe in the nose, and all we see is bone, and we're wondering where exactly is the carotid artery. We can actually use that probe to isolate where it is, making the surgery more safe, allowing us to go where we need to go and not where we don't need to go.